A patient with severe community-acquired pneumonia undergoes a rapid respiratory decline, despite receiving standard first-line treatment. Following a transfer to the ICU, their vitals continue to destabilize. The clinical team must now adapt the treatment plan within a narrow window. The standard protocol for escalation is to introduce an ultra-broad-spectrum carbapenem, such as meropenem. Meropenem achieves high concentrations in both the serum and the interstitial fluid. It is a potent bactericidal agent, capable of clearing typical gram-positive and gram-negative organisms found in these extracellular spaces. Yet, a clinical anomaly emerges. Even with high-dose meropenem, the patient's white blood cell count remains elevated, and inflammation does not subside. Potency at the serum level does not always guarantee that the drug is reaching the specific cellular compartments where the infection is most active. Due to its chemical structure, meropenem is effectively blind to certain biological spaces, circulating through the vasculature without ever penetrating the host cells. Sterilizing the extracellular fluid provides no benefit if the primary pathological driver is insulated from the bloodstream. This failure of delivery creates a pharmacokinetic paradox. The clinical failure points point toward atypical pathogens, organisms that bypass the standard logic used to calculate minimum inhibitory concentration, or MIC. In severe, non-responsive pneumonia, the hidden culprit is frequently Legionella pneumophila, seen here in its characteristic rod-shaped morphology. Beta-lactams, like meropenem, are hydrophilic. These water-soluble molecules remain trapped in the aqueous extracellular space, unable to pass through oily cell membranes. Paradoxically, the host's immune defense creates a sanctuary for these pathogens. Alveolar macrophages engulf Legionella, but the bacteria survive the process, moving the infection into the intracellular space. While the bacteria would be vulnerable to antibiotics in the blood, they are protected once they are inside the macrophage. They are physically shielded from cell wall active agents. This intracellular sanctuary acts as a pharmacokinetic dead zone for any drug with a low volume of distribution. Simply increasing the dose of a carbapenem will not overcome this physical barrier. The molecule is chemically barred from entry. The clinical crisis is not caused by a lack of drug potency, but by a failure to deliver that potency into the intracellular microenvironment. Legionella enters the macrophage through coiling phagocytosis. It subverts the host cell's own biology to be pulled into the interior. Once inside, the pathogen utilizes the complex internal biology of the macrophage. These organelles provide the infrastructure the bacteria need to replicate. The bacteria actively prevent phagolysosomal fusion, which stops the macrophage from using its digestive enzymes to destroy them. To reach this replication vacuole, an antibiotic must be lipophilic, meaning it is fat-soluble and can dissolve through multiple lipid membranes. The first obstacle is the macrophage's exterior phospholipid bilayer, which blocks most standard antibiotics. This barrier is why highly potent drugs like aminoglycosides fail in these cases, as it must be targeted to the specific acidic environment where the bacteria are hiding. Eradicating this infection requires a pharmacokinetic profile that converts the host cell from a protective sanctuary into a lethal trap. Azithromycin, seen here in a 250 mg dose, is the prototype for macrolides with a high volume of distribution, or VD. In the neutral environment of the serum, azithromycin is uncharged. This allows it to passively diffuse straight across the macrophage's phospholipid bilayer. Unlike other drug classes, it does not require high-energy active transport. It simply slips through the lipid tails of the membrane. This rapid movement into the cells explains the discrepancy in its behavior. While its serum half-life is relatively short, its tissue half-life extends for several days. This distribution is made possible by the weak base property of the macrolide molecule. The drug encounters a sharp pH gradient as it moves. The serum is neutral at pH 7.4, while the internal phagolysosome is acidic, ranging from pH 4.5 to 5.5. This shift in pH will fundamentally change the physical properties of the azithromycin molecule once it crosses into the acidic zone. Azithromycin is chemically engineered to exploit the host cell's internal pH to ensure clinical success. This is achieved through ion trapping, a biophysical process where a molecule becomes physically unable to leave a compartment once it enters. This diagram illustrates the process. In the serum, drug levels are often quite low, leading to a misleading assessment of total drug present. When the drug enters the macrophage's acidic compartment, it becomes protonated, gaining a positive electrical charge. This charge makes the molecule hydrophilic. It cannot dissolve back through the lipid membrane, locking it inside the cell. This one-way valve effect means the drug continually pours in, piling up to levels 100 times higher than those found in the blood. This 100-fold increase ensures the drug concentration far exceeds the level needed to kill the intracellular pathogen. The antibiotic is now physically delivered to the exact replication vacuole inhabited by the bacteria. Azithromycin efficacy is driven by this concentrated intracellular loading rather than serum concentration. This forces a re-evaluation of how we define therapeutic levels. While this happens at the cellular level, it has profound implications for the inflammatory response throughout the lungs. Through the process of chemotaxis, the body pulls macrophages toward the highest concentration of bacteria. The azithromycin-loaded cell operates as a mobile pharmaceutical delivery vehicle. This movement overcomes the poor blood flow often seen in infected lung tissue, where standard IV antibiotic delivery might fail to reach the site. As the macrophage interacts with the pathogen, the concentrated drug is released directly at the source of infection. The host's immune system and the macrolide work in a synergistic partnership to achieve site-specific eradication. This explains why clinicians utilize both broad-spectrum agents and targeted macrolides for patients with severe pneumonia. A two-pronged attack is necessary to cover every possible physical space where bacteria might hide. As this chart demonstrates, the two classes operate in different physical spaces. Meropenem clears the extracellular fluid, while azithromycin penetrates the intracellular vacuoles. Total clinical success requires the sterilization of both the bloodstream and these cellular sanctuaries. Stewardship means selecting the drug that fits the specific biological compartment of the infection, not just the one with the broadest spectrum of activity. In the fight against infection, the drug's spectrum of activity matters only if the molecule can reach the physical space where the pathogen is replicating.